All right, good morning, everybody, and welcome to June 9th. So I hope this lecture will cover, across the board, from some beginning topics to some more advanced topics. So I want to go through gross histology correlates of thyroid as well as thyroid grossing. For the first years, myself and Katie, our new fellow, will be over in the gross room later this morning after the lecture to come and work you through some head and neck specimens. So see you guys soon. And please, I'd like this to be interactive, so if you guys have comments, questions, please stop me. But essentially, we receive over 300 thyroidectomies per year. That includes both lobectomies and or total thyroidectomies. So these are specimens you will see with frequency, which ends up being over one per workday. Sometimes there's none a day and sometimes there's a few a day. So you will see a lot. You will gross a lot of thyroids. I'm going to show you examples of cases kind of as I saw them at sign out, because it's easy to say, like, here's what you should do and follow these directions, but I want to give you a little bit of perspective of how it is from the opposite end and sort of what I'm looking for when I sign out these cases. So we're going to go through some of those cases. If you see cases that you grossed on here, don't be offended. It's not to shame or promote anyone. It's just to go through some common pitfalls, and these are pitfalls that everyone makes. We're going to do a correlation between the clinical, the FNA, the gross, the histology, and we'll go through some guidance for how to approach grossing of thyroid, because not everyone is the same, even though they are overlapping and they can certainly be very similar. They are each different. So with that being said, does anybody have any comments or questions before I begin? Otherwise, we'll start with the first case.
You.
Sorry, what? No.
No, go ahead.
Okay. All right, so case one. So I read in my clinical history on the paperwork that comes with the case, the patient's undergoing a right lobectomy for goiter. The specimen weighs 259 grams. Remember, with all endocrine organs, they should all be weighed, regardless of how small or big they are. I will make one point while I'm here, is that for things like parathyroid especially, that may have some attached fat with them, any endocrine organ that has some attached fat on it, you could certainly weigh intact, but if you can, then remove the fat and weigh the glandular portion of the organ separately. That is sometimes more helpful, more accurate, just an aside. Okay, so this goiter weighed 259 grams. The overall size was 10.8 by 8.3 by 4.6, and so that's one lobe. The gross description was multiple fluid-filled hemorrhagic nodules, and there were gross photographs. Excellent. So let's go look at the gross photographs. But first, I want to ask you, this patient comes with a quote-unquote goiter. So if you can see that poll, I'd like you to answer the poll for what is a goiter. Because I think this is potentially confusing. %, 76% voted, 80% voted, 85% voted. Can we get to 100? It's all right, I'll accept 90%. Okay, so you said 32% of people said non-neoplastic thyroid enlargement, and 68% of people said generic thyroid enlargement, and none of you answered any of the middle. So for those of you who answered generic thyroid enlargement, that really is the answer. So clinical perception of goiter is basically big thyroid. And so the determination of what is neoplastic versus non-neoplastic, infectious, inflammatory, really that is a combination of the clinical, the ultrasonographic, and the histologic features. Specifically, definitive diagnosis relying on us, right, on the histopathology. So when you say goiter, you can't assume that it's not a tumor, okay? Because that literally just means the thyroid is big. So don't ever make that assumption. So here is the gross photograph of that first case, okay? So the gross photograph of that first case was described, remember, as multiple nodules. So I'm going to launch the second poll, and I'm going to say, do you see what I see? Is this a single nodule or a multiple nodules? %71 voted. I need my little Jeopardy music in the background. It's okay, just look at the poop pillow if you're done. All right, I'll take 76% voted. All right, so again, those of you who said single nodule, which would be 69%, versus multiple nodules, 31%. So yes, I see a single nodule. So I see a relatively circumscribed area that sort of stands out from the background, right? And so background thyroid that is non-neoplastic, non-lesional, tends to be very homogeneous and brown, sometimes lighter and sometimes darker. But really, if you can draw a smooth border around a pushing shape, to me, that's a single nodule. The center has cystic degeneration, the center has hemorrhagic change, but arguably to me, this is a single nodule. So here is the histologic correlate of that. So on a sort of 1x view of that slide, so what I saw on the slide was a nice compressed rim, in this case of vascular and fibroadipose tissue, and then a nodule with a large arc, right? A large arc. And then on higher power, you see multiple small follicles with sort of small round nuclei. Some of them are very compressed so that you don't get too much colloid. Some of them have this stromal edema in between, sort of pushing the follicles out and become widely spaced. Here they're colloid filled. So does anybody want to give a diagnosis for this case? And then we'll go through how I would have approached this. Think about it. So when I saw that there was a discrepancy between the gross description, multiple fluid-filled nodules, the gross photograph that I saw, and the histology, which wasn't really multiple, every single section looked like that, right? A large arc with microfollicles in the center. So I went back to COPATH and I said, oh, there actually is a prior FNA of that right lobe nodule. Ultrasound-guided FNA diagnosis was benign follicular nodule. Epic ultrasound said the right lobe is predominantly occupied by a mass that is partially solid and partially cystic. Okay, kind of jives with what we saw on the gross, and measures 11.4 by 5 by 7. Wow, that's big. 11 centimeters is big. The left lobe measured that without nodules, the isthmus, lymph nodes, unremarkable. So basically, large, low suspicion nodule in the right thyroid lobe, amenable to biopsy, which was performed and called benign. So in this case, what is the goiter, right? So this patient comes in with a quote unquote goiter. Remember that when, this is just a technical issue, when the nurses are entering the clinical history into op time in the OR, they don't always say this patient had a thyroid nodule with a biopsy that was benign, right? They don't put all that in. It's all drop-down menus. They go to thyroid, and like the first thing that they see is goiter, multinodular goiter, right? So basically, unless the patient has something like a Hashimoto's or a Graves or something where they're getting the thyroid out for medical management, any nodular thyroid, whether it be benign, malignant, tumor, whatever, often just gets goiter, okay? So don't trust goiter. So in this case, from the multiple fluid-filled hemorrhagic nodules, what we did was we went back and we measured from the photo, okay? Because we didn't have a gross measurement necessarily of the size of that thing, we at least got a single dimension from the gross photograph. So I called this a microfollicular adenomatous nodule with stromal degenerative change. There was also some para at the side. All right, the nodule measured at least 8.5 centimeters based on representative gross image. So right, micro, because the follicles are small and compressed, and adenomatous, because it's benign, essentially, right? So when we do the thyroid histology lecture, we'll talk about all these descriptive diagnostic terms, but for me, adenomatous implies essentially anything that is a benign lesion. So because this wasn't measured grossly in 3 dimensions, that largest dimension was lost, right? Presumably you're serially sectioning it perpendicular to the long axis, so one would have to go back and remeasure that long axis. So in this case, we at least got the cross axis. Okay. Questions or comments? All right, case 2. The patient is undergoing a left lobectomy for goiter. The requisition says thyroid nodule, but this did not make it into COPATH. The specimen weighed 109 grams, overall 7 by 5 by 3 centimeters. Gross description was red and variably translucent, mucoid, no cysts. Gross photographs, yes. Oops. So again, I'm going to relaunch the poll, and I want you to tell me what you see. (72% voted. I'll take it because you're learning. Now 94% of people said single nodule, all right? So again, in this case, there does appear to be a rim of kind of bland, brownish thyroid at the bottom, right? And this more gelatinous nodule that you can draw a line around its pushing border. There are some flecks, maybe some hard colloid in there. There's some more dark brown and some more reddish brown areas, but essentially this appears to be a solitary pushing lesion. Oh wow, that sun's in my eyes. Excuse me, I'm just gonna close it for a second. If I can reach it. Okay, great. All right, so comparing that with the microscopy, what do we see now? We see, again, a very large arc, right? We see a large arc that occupies almost the entire slide. We see some normal thyroid tissue on the right with follicles of very even shapes and sizes. And then on the left, contained within that arc, right, we see large follicles, small follicles, much more heterogeneous size. So to me, that's the lesional area, right, compared to the area on the right that is the normal rim. Here's a higher power of that lesion with the normal compressed rim on the left, and these large follicles on the right, with lots and lots of colloid, with small, bland nuclei, okay? Again, we're gonna check COPATH and see, was there any prior biopsy? In this case, there wasn't anything that we reviewed at this hospital, but we're of course gonna check the ultrasound findings from EPIC and say, we're dealing with the the left lobe now, so there is a solid ISO to hyperechoic nodule replacing the majority of the left gland, measuring 6.5 by 3.4 by 6. Low suspicion, nothing in the right, nothing in the nothing big in the right, and nothing in the isthmus. So low suspicion nodules, a dominant large one in the left. Okay. So in this case, what is the goiter? Again, we're going to make a diagnosis of macrofollicular adenomatous nodule. Macro because the follicles are large and full of colloid. And again, we're going to go back and measure it from that gross photograph. The nodule measures at least 3.5 centimeters based on representative gross image. Again, not measured in 3 dimensions, largest dimension lost. So in this case, yep, I'm sounding like a broken record, but this just happened to us yesterday or the other day. So I don't even know who grossed it, but same thing. I kindly asked my resident to go back to the bucket and reconstruct it and go back and line those slices up and try to measure the nodule in that 3rd dimension. So there's 2 options, right? You can get one measurement from the gross photograph if a gross photograph is taken. In this case, a gross photograph was not taken, so I asked her to go back to the bucket, take a photograph, and arrange the slices and measure that third dimension, right? So now we have a measurement of the nodule. You may ask, does it matter? It's benign. Well, it gives better justice to why this patient is having a thyroidectomy, right? It correlates better with the clinical and the ultrasonographic features. So I prefer to give that gross measurement because it accurately reflects what is actually going on in this patient. Okay, does that make sense to everybody? All right. Questions, comments? Thank you. All right, case 3. We're going to shift gears a little bit. Now the patient is undergoing total thyroidectomy for quote unquote toxic multinodular goiter. What does toxic mean?
When you hear toxic, you generally associate that as being hormonally active. So you think of someone with a toxic nodule, you think of them as it being productive of thyroid hormone, and then therefore being clinically hyperthyroid.
Excellent. So toxic implies clinical hyperthyroidism. And I know the books will tell you hyperthyroid or toxic or hot nodules are likely benign. Not always the case. Okay, so nothing ever reads the book. In this case, what does the gross description from the prosector say, right? So when you're grossing and you're saying toxic multinodular goiter, and you're giving this very nice complex gross description, to me that implies, well, did you go into the chart to see the clinical history if you're just reading toxic multinodular goiter? Because usually there's something else, right? As we saw in the prior 2 cases, there were either an FNA, there was some ultrasonographic findings of a dominant nodule, right? So if you tell me this patient had a goiter, I think you didn't go into the medical record to read anything about this patient. So just letting you know. All right, in this case, the grosser said the left lobe was 246 grams and the right lobe was 11 grams. Does that make sense for a diffuse multiple nodular bilateral goiter where the one lobe is 10-fold larger than the other lobe? Not really. So what do they say about the left lobe? It's 12 centimeters. The entire lobe is overtaken by a firm, fleshy, variegated lesion with central hemorrhage and necrosis. Necrosis, never good, all right? Never good. That nodule measures 12.5 centimeters, essentially the entire lobe. However, 2 slices in the middle demonstrate a vague septation. See gross photograph. Excellent, thank you. Raises the possibility that the 2 nodules are coalescing and separating. Okay, so if these nodules are measured separately, the superior pole 1 measures 4.2 and the inferior pole 1 measures 6.5. So thank you, that's helpful. So now we have an entire measurement of the 3 dimensions of the one larger nodule, and we have which essentially occupies the entire lobe. And we have 2 measurements of those 2 smaller, perhaps coalescing nodules. So depending on what we see grossly, we can either lump them together or, depending on what we see histologically, we can either lump them together or split them apart if they're the same or different, okay? So nothing in the right lobe. Let's check the gross photos. So again, does this look like a classic toxic multinodular goiter, right? Classic multinodular goiter is diffuse and bilateral and is usually related to iodine deficiency and should involve everything, right? So no, it doesn't look like that. Okay. So again, beware goiter. Goiter is literally just a swelling of the neck resulting from any generic enlargement of the thyroid gland. This comes from the French goitre. I don't speak French, but goitre, having a goiter, goitron, gullet, or guttural throat, right? So it's basically like you got a big gullet, all right? Goiter, you got a big throat. It does not imply cause. It does not imply inflammation. It does not imply autoimmune disease. It does not imply benignity. It does not imply malignancy. It can be any of those. So just hammering this point home, all right? All right. COPATH says, left thyroid FNA, suspicious for follicular neoplasm. So we'll talk about Bethesda later on in this lecture. EPIC says, let's go to chart review, let's look at the imaging, and let's look at the ultrasound. Left superior pole nodule 5.7, left inferior pole nodule 6.3, increased in size. All right, so the grosser correctly kind of broke out those two nodules. H&P in the chart, the left 5 centimeter nodule was then FNA'd and showed FLUS. Molecular testing showed 95% risk of malignancy. All right, so what am I going to tell you to do? I'm going to tell you to go find that molecular report. So 95% risk of malignancy, that's very high. What did they find? All right. So if you can't find it right away, where are you going to go? So for those of you who are new to EPIC, right, you can go into Media tab. Media often has scanned images from external sources, external radiology, external pathology, external notes, external molecular testing, whatever. So in this case, there was a scanned report of the ThyGenX Thyromere molecular test. It said left thyroid FNA had an NRAS mutation and TERT. Who wants to interpret that for me? What are you guys thinking when you see that? Anybody? What does NRAS imply? What does TERT imply? Because they imply two different things. So RAS implies some kind of follicular neoplasm. Okay. And TERT, somebody wrote hobnail variant. I'm going to take a step back. Hobnail variant could potentially be aggressive. TERT certainly is implied to be aggressive. TERT doesn't necessarily imply hobnail variant. TERT implies aggressivity, all right? But hobnail variant could also be aggressive. So I see your thought process there, all right? So we're looking for a follicular neoplasm, and we're looking for potentially something aggressive, all right? So here's the gross photo. What do we see? We see a relatively circumscribed lesion with some heterogeneity, some gelatinous center, some hemorrhage, and perhaps a little satellite nodule out here, right? So this is a little different than the rest. So the others didn't have this little satellite nodule on the periphery. This does. So that should already be concerning for you. So nodules that are solitary and benign usually don't have outpouchings, finger-like projections, satellite nodules. So let's take a closer look at that. So here's the histology of that satellite nodule. Again, the larger component of the neoplasm is on the top, and that satellite nodule is on the bottom. Is it the same or is it different? That's going to require a little closer histologic examination, but already we can see that there's some irregularity here. Okay. Now, remember that description of the two coalescing nodules? Well, perhaps this is what the grosser was seeing, sort of a dumbbell shape, right? Where you have a cinch in the middle and an outpouching on the right and on the left. Again, this is a little bit of an irregular border. So even though you can draw a line around it, the line is sort of undulating, right? And or there was a second little satellite nodule in that prior photograph. So these are all grossly worrisome features. If it's a solitary, dominant, benign nodule, it should grow and expand and push the thyroid out and not really have fluctuations, undulations, or satellites, okay? So this is already suspicious. All right, what else do we see on closer examination of this gross photograph? We see some very fleshy, white, tan, almost solid areas, all right? So whenever you see these dense, solid areas in thyroid, that should be concerning to you. If it's gelatinous and gooey, that implies more kind of colloid, sticky, right? But if it's very solid and firm, that should imply something more aggressive. So in this case, higher power of that solid area, in fact, shows solid growth histologically. We'll talk about what that means. But let's look on closer power. We see wall-to-wall thyroid cells with only a couple follicles scattered in between. We start to see wrinkling or raisonoid change of the nuclei or convoluted change of the nuclei. So those of you who are seniors might see what I'm getting at. We also see a mitosis, also not good, okay? Let's go back to the gross and start searching for other higher risk features. All right, so now we see this gelatinous, maybe opaque Areas, let's see what those look like. Well, what do you see on the bottom right here? You see this area that's essentially void of nuclear detail and appears kind of grungy. And again, on higher power, you see a small area of that loss of nuclear detail, of grungy, gritty material that's surrounded by viable cells. So what am I looking at here? Please write something. Thank you. Necrosis, comedo-necrosis, exactly. So this is necrosis in a thyroid. Never, ever good, okay? So you have solid growth, you have necrosis, you have mitoses, okay? So is this just a toxic multinodular goiter? This is way worse, all right? This is probably one of the worst thyroid cancers you can get, okay? So this is a thyroid carcinoma with follicular and poorly differentiated features. Poorly differentiated being excellent, thank you, being solid growth, mitoses, necrosis, okay? When we do our thyroid histology lecture, we'll talk in more detail about poorly diff, but this is only one step below anaplastic, all right? So those microscopic features, we were able to go back to the gross and see, right? So you can see those things. So please be careful when you're looking at thyroid. And I know that sometimes when you see common specimens like thyroid, like prostate, you kind of do them almost remotely or rotely in your brain. But I would argue, please just take the moment to look at those cut surfaces, evaluate what you see, and submit sections appropriately. So a toxic multinodular goiter is not always just a multinodular goiter. Use the medical record, carefully evaluate the growth, and there's often more there than you think. And so the molecular, right, the RAS mutation and the TERT promoter mutation already warned us that this was a potentially aggressive thing, and we showed it, right? So poorly diff, TERT promoter, all correlate. So this is a perfect correlation from ultrasound to FNA to final diagnosis, okay? So you can gain a lot of information from the medical record. Next case, patients undergoing total thyroidectomy and neck dissection for PTC. Oh, okay, so we have an actual PTC diagnosis now. Excellent. 13.7 grams, gross description of the right and lower nodule, 2.2 centimeters, well circumscribed. Gross ETE, not definitively identified. We'll talk about why this is important. Gross photographs, yes. So let's look at those gross photographs. Well circumscribed or infiltrative. Now, based on what you know, what already is a little bit worrisome here based on the photograph we already saw? Weird outpouching, infiltrative, satellite, exactly, right? So that satellite nodule there, that weird, funny, undulating border, none of mushroom cap, exactly, none of that is okay for a benign nodule. So this is white, this is firm, this is solid. This has a little cystic area in the middle, okay, but that border is not kosher, all right? There's perhaps a little bit of pink in the center. That's probably just due to incomplete fixation, so it might be a little bit softer. Okay, fine. So this is invasive grossly, excellent. So let's recapitulate that microscopically. So we see that satellite nodule here on the left. We see that undulating border on the top and on the bottom. We see very solid. We see papillae. We even see that cyst, right? So again, perfect gross microscopic correlation. Let's go look on higher power at that satellite nodule. Wow. Well, it's a blood vessel, right, with kind of a thin wall with lots of blood in the center, with an artery next door. And you see a large plug of tumor that is endothelialized, all right, that has an endothelial lining and is pushing into a blood vessel. So this is certainly suspicious for possible angioinvasion, all right? And that was something that we could even see grossly, all right? So the lesson here is you can see meaningful things grossly. Just look for them, document them, photograph them so others can see. You know, you have the privilege of dealing with that fresh, you know, or fixed gross specimen, but certainly you have the privilege of dealing with that gross specimen, whereas those of us at this end don't always have that privilege. And so please allow us the opportunity to see what you see. And from my perspective, it's very, very helpful to have those gross images because they often provide a lot of information. So thank you for being diligent about taking them, and please continue to do so. Do we have questions or comments before I move on? Now we're going to get into some more kind of general topics. So if you haven't already, please refer yourself to the Gross Photography page on the website. My generic tips are clean the background surface, clean the specimen, center the specimen in the frame, and zoom in as far as possible for best auto exposure, right? Because that camera, it's not a fancy photographic camera. We can't adjust the settings too much, and it auto exposes. So when you're way out here, it doesn't appropriately evaluate the tissue, so zoom in as far as you possibly can. If you don't get the whole ruler in, that's okay. Just push the ruler into the edge so we can see the numbers. But don't worry about, oh, I need to get the whole ruler and sacrifice the specimen. Fine, take one like that if you want the overview, but then zoom in so that you see it very closely. Okay. I take photographs, as I've told some of you, with the light stand on and with the light stand off, because sometimes one is better than the other. And so we have our choice of the best, the pick of the litter. So if you photograph the external surface, which can be important for overall orientation of the specimen, please don't forget to photograph the cut surface, which is important for lesion-specific information, right? Orientation, lesion. All right, or I will be very sad. All right. General approach to grossing thyroids. So one thing I will start out with is by saying that very rarely do we get frozens for thyroid anymore. This used to be historically present in the past. They would be looking for cancer. They'd be like, oh, this had an indeterminate FNA. I'm going to see if we can find cancer. Well, unfortunately, the intraoperative diagnosis is usually not very different from the FNA diagnosis and does not change intraoperative management. So surgeons have essentially stopped frozen sections in this hospital with rare exception. If you get one of those rare exception cases of a frozen, of a thyroid, please take a smear or a touch prep or some cytologic evaluation of that fresh nodule in order to preserve the nuclear features. Because when you freeze thyroid, your ice crystals blow out the nuclei, and it makes it very hard to differentiate PTC from a bland follicular neoplasm. So even if your attending is not a cytologist, I don't care, do it anyway. So here, when we have one together in the gross room, we'll do it together. But sometimes I find that epithelial tumors, unlike lymphoid tumors, don't stick very well to the slide if you just, touch the tissue to it, especially if it's very bloody or very colloidy. You might just get blood and colloid and not a lot of cells. So what I do is I wipe off the blood and the colloid from the surface of the cut thyroid, okay? I will take a scalpel blade and scrape the nodule, scrape the cells off of the nodule, and then dab those cells onto a slide, as you see in the picture. Take a second slide like you would in your cytology, right, in your FNAs, and smear it. All right, so then you have two slides and you stain both of those. So that is my preferred way of doing a smear on fresh epithelial tissues to actually make sure you are getting the epithelial tissue off the thing. Stain with your choice of H&E or air-dried Diff Quick. So just as a reminder, when you're staining smears, here's what you do. If you're doing an H&E smear, make sure you have your alcoholic formalin jar with you and place that smeared slide immediately into the alcoholic formalin, stain it regularly with your H&E process, and cover slip immediately. If you're doing a Diff Quick smear, you gotta grab those Diff Quicks from the heme bucket, right? After you smear it, let the slide air dry completely. Don't touch it, don't put it in anything, smear it and sit it on the counter, all right? Once it's completely air dried, then you stain with the Diff Quick. Then you let it air dry completely again before cover slipping, okay? It's the consistency of the stain that requires air drying both before and after. So you can view the slide, the Diff Quick slide wet without a cover slip. It just may look a little bit blurry, but if you want it to dry faster, you can put it in the fume hood to get those evaporating happening. But really, please don't cover slip until it's completely dry. Okay. All right. As an aside, because we like to correlate things, right? You can also use that Diff Quick stain when looking for invasive fungal sinusitis on cut frozen tissue in order to highlight the fungal cell walls, all right? So this is how we would do it if we were doing it for fungus. Cut a slide from the cryostat from the sinusitis case as you normally would. Again, do not place that thing in the alcoholic formalin, let it air dry. Once it's air dried, then you do your diff quick, and then again, you let it air dry again before cover slipping. And so if you ever have an invasive fungal sinusitis case, I would argue cut your H&Es and cut another one for diff quick, let it air dry, and stain it up once it dries. All right, so this is helpful to pop out those cell walls. My 2 uses of diff quick are here. All right, questions, comments? Has anybody done that? If not, we'll do it together someday. Okay. So my general approach to grossing thyroidectomies in the last 15 minutes or so, we got frozens out of the way. Hopefully you won't see many of those, but if you do, you know how to handle them. Oh, I should mention, if you do get a frozen, in addition to doing that smear, you should also do the actual frozen. You should just have both. Okay, thank you. All right, so the reason we fix thyroids overnight, similar to the reason we fix prostates overnight, is because of the solidification of the edge, essentially. It's not a capsule, right? So things that we like fixation to do. Fixation better preserves the nuclear features to distinguish papillary carcinoma from not. It preserves the integrity of the peripheral margins of the specimen, right? The fibrovascular plane. I'm not going to say capsule. But it does preserve also the integrity of the tumor capsule, if there is one, right? So the thyroid gland itself does not have a capsule, just a plane, just like prostate. But tumors in the thyroid could actually have tumor capsules. And we also want to preserve the integrity of those. I don't know how many of you have seen thyroids grossed fresh or consults from the outside or unknown slides, if, for example, where hospitals in the community often get frozens for thyroid, often cut them fresh, and it ends up being occasionally a mess because you get kind of shifting of tissues, you get compression and expansion during the cutting process, you get artifactual potential invasion that isn't there. So I really think this is a problem and could overdiagnose potential cancers when they don't exist. So this is why we fix them overnight. All right. Always check those ultrasound and FNA results to see what you should be looking for when you cut into that gland. The size, the location from the ultrasound, the FNA diagnosis, benign, indeterminate, or malignant. These can certainly help your grossing. So what are those FNA diagnostic categories? So for those of you who've gone through cytology, you should know this. For those of you who haven't, here's a quick review. So we're not going to really worry about unsatisfactory because usually these people undergo repeat FNAs. What we worry about are Bethesda category 2, benign, in which case the patient usually only undergoes surgery if symptomatic. Bethesda category 5, 6, suspicious for malignancy or malignant, where most of those will go for surgery, either lobectomy or total thyroidectomy, depending on clinical features. And then there's the intermediate categories, the indeterminate, Bethesda 3 and Bethesda 4, atypia of undetermined significance, which tends to be, in this institution, diagnosed with nuclear atypia, and follicular lesion of undetermined significance, which tends to be diagnosed with more architectural microfollicular atypia rather than nuclear atypia, and then follicular neoplasm, very cellular, very solid, okay? So in Bethesda 3 or 4, these patients often undergo molecular testing on FNA and surgical resection for definitive diagnosis, i.e. diagnostic lobectomy, okay? So why do patients undergo a lobe versus a total? So usually a lobe is for definitive diagnosis of those indeterminate nodules like 3, 4, and sometimes 5, or treatment of a very low risk, small cancer, node negative that does not need radioactive iodine, all right? A patient might undergo, on the other hand, total for symptomatic relief of non-neoplastic disease like true multinodular bilateral compressive goiter, Graves, Hashimoto's, or treatment of a higher risk carcinoma that does need radioactive iodine, right? So total thyroidectomy is no longer the default for cancer. Why do patients with cancer need a total? only if they're going to get radioactive iodine, such that the remaining normal thyroid doesn't sink with the iodine and prevent it from attacking all of the cells that may be circulating in the periphery or whatever, right? So total thyroidectomy is only warranted if the patient is undergoing radioactive iodine treatment. Okay. All right, so going back to molecular testing on FNA, I want to just regroup on how we can use it to help us, all right? So remember, this is Bethesda 3, 4, sometimes 5. There are 3 generically commercially available tests. That's Verocytes Afirma, that's Interpace Thyromira and Thigenex, and that's ThyroSeq. We here, our cytopathologists and our clinicians, send to Interpace. So those are the reports you will see from our specimens. But if you're seeing consult cytology, you may see Afirma and you may see ThyroSeq. What they all do is a gene expression profile that sorts nodules into gene expression patterns that are more commonly seen in benign versus malignant. So that's messenger RNA, microRNA, that's just global expression profiles. The second in green are specific single gene mutations or fusions that are specifically present in thyroid neoplasms, all right? Some are specific to malignancy and some are not, right? So expression profile, generic, mutational or fusion panel, specific. They all do both. If you get a negative result on that gene expression profile, that basically takes your indeterminate nodule and puts it into a molecularly benign category, 4 to 5% risk of malignancy, all right? So a negative result is very, very helpful to rule out malignancy and avoid surgical intervention in these patients. However, a positive or a suspicious result is highly variable and depends on the nature of the mutation that is identified, ranging anywhere from 25 to 99% risk of malignancy, okay? So you really have to read what a positive result means. Or in the case I saw before, right, 95% risk of malignancy, what does that mean? Why? So look into it. These are the mutations that you're gonna be looking for. You're gonna be looking for mutations that are found in follicular neoplasms, i.e. RAS or Pax8 PPAR gamma rearrangements are the most common, but this is found in both benign and malignant follicular adenomas and follicular carcinomas. You're going to be looking specifically for BRAF V600E or RET PTC rearrangements, which are specific to PTC. You're going to be looking for high-risk mutations like TP53 or TERT promoter, which often are found in the more aggressive poorly diff or undiff / anaplastic. And then lastly, you might be looking for something like a RET mutation, which should really only be seen in medullary cancers, okay? So not every thyroid neoplasm has one of these, but if you're going to see something, it's probably going to be in this group. In some cases, the genetic drivers are unknown, and in some cases, the genetic drivers are less frequent rearrangements or mutations, okay, like NTRK, etc. Okay. So in summary, with the benign gene expression profile on FNA, these patients undergo observation because they have been dropped down from an indeterminate nodule with a higher risk of malignancy to an effectively molecularly benign nodule. With a positive, suspicious, or indeterminate result, these patients will likely still undergo diagnostic lobectomy. Then look at the mutational profile, right? If a cancer-specific mutation is found, these people undergo resection for cancer. If a non-cancer specific mutation is found, but a neoplasm-specific mutation is found, right, like RAS, these will still undergo diagnostic lobectomy, right? So all of these that I've highlighted, you're gonna see in the gross room. You're gonna see all of them. What does this mean for grossing? This means if you don't have any specific genetics or follicular neoplasm genetics, we've got to make a diagnosis of benign or malignant because this is a diagnostic lobectomy, all right? If you see PTC or MTC genetics, we've got to do appropriate staging. And if you see high-grade genetics like TERT or P53, we have to search for those high-grade features. And I think we've kind of seen examples of some of those in the grossing. So just as a reminder, the types of thyroidectomies we're going to get are lobes, which are just a lobe without much isthmus, or a hemi, which is a lobe with an isthmus. In both of those circumstances, you're going to ink only the cut parenchymal isthmic margin, one color, usually orange, and you're going to cut the peripheral surface, another color. Why are we doing it in this fashion? Those of you who have already grossed these. All quiet on the Western Front. Why the different blue and black or orange? Sorry, I missed the question. So why are we inking that cut surface orange and everything else a second color in a lobectomy?
To denote the true margin?
To denote the
Yeah.
true.
Also to see if the tumor is extending, let's say we have cancer in one of the lobes, if it's extending through into possibly the other lobe.
Yes. So the cut parenchymal margin tells you that the interface with the opposite thyroid lobe, and the peripheral margin, right, tells you the interface with the other neck tissues. So if this is really a cancer and it is present at the margin, the surgeon will want to know, is this at the isthmic margin? I can go back and take more of the thyroid out, or is this at the peripheral margin? If it's at the peripheral margin, they don't do anything else, right? That the interestingly in thyroid, peripheral margin positivity does not require re-excision. It requires probably radioactive iodine for microscopic disease. However, a positive isthmic margin, they know if they go and take the other lobe out, the patient is clear, right? So that is why we ink it that way. All right. In a total thyroidectomy, we'd ink the left, right, our sinister hand black, and the right blue. If the isthmus is visible, we ink it a third color orange, just so we have anatomic separation of the lobes in the isthmus, and it reflects on the slides, all right? If the isthmus is narrow, I would say don't bother inking it a third color. Okay, section perpendicular to the long axis. In your lobectomies or your hemithyroidectomies, do not section the isthmus sagittally, just continue your sections perpendicularly so that you can have a perpendicular margin of that isthmic cut, okay? However, if it's a total with a long isthmus, you can section that sagittally from left to right. All right. It's just, this is all in the Gross online manual. All right, so if you have a nodule then after you've cut it, that's infiltrative or circumscribed but not obviously encapsulated, I would say arguably about a section per centimeter. If you're uncertain about the capsule, I would allow you to submit a few additional cassettes of that peripheral interface with normal as in this diagram. If there is a true capsule, we can always go back for more. Here's an example of a lesion that is circumscribed, right, but unencapsulated. There is no white fibrous band. On the next slide, you're going to see true capsules. So these are nodules that have white fibrous bands at the edge. These arguably are true capsules. So in this case, if you see a true capsule, you can submit a few, even more additional cassettes of that tumor capsule interface. I would argue, because we've had issues in the past where the entire periphery of a 6 centimeter nodule is submitted and we get like 50 cassettes, I would not do that up front. I would do a few extra, 5-ish or so, 5 to 10 extra cassettes if you see a capsule, and we can always go back for more if we need it later. Because if we have a diagnosis of cancer, we may not need the whole thing. If we don't have a diagnosis of cancer and we're worried, we may go back for more, right? So I will allow some flexibility. If you don't want to submit the whole capsule, you shouldn't submit the whole capsule up front, but please give me a few extra strips if you're concerned. And that will let me know that you're concerned. All right. Comments, questions? Why do we care? Of course, because in a follicular neoplasm, we have to distinguish follicular adenoma from follicular carcinoma. The only way to do that is through transcapsular invasion or vascular invasion. Usually the vascular invasion is in vessels just within or just outside the capsule. And usually those are microscopically seen only. Usually in follicular carcinomas, those are not grossly seen, okay? So just be careful, even if it looks circumscribed, there may be microscopic invasion, hence why we have to be careful of that periphery, okay? An alternate way to evaluate these follicular neoplasms is a so-called modified transverse vertical, all right? So what does this mean? So this is a proposal to better evaluate the tips or the poles of that capsule, similar to perpendicular margins of a lumpectomy, etc. So in our normal processing, we just do 100% transverse top to bottom, okay? In this modified approach, you would only transversely section through the center of the nodule but perpendicularly section through the poles of the nodule in order to get potential invasion at the periphery visualized in a perpendicular fashion, right? Rather than a sort of en face fashion, because you're never going to see good invasion just by looking down at the capsule. You have to see it perpendicularly. Does this all make sense? So how I would argue that you would do this is if you have a dominant nodule, solid follicular neoplasm type of picture, not necessarily PTC, but follicular neoplasm, you would perhaps bisect it longitudinally, open up the two halves of the thyroid, and then determine where the top and the bottom of the nodule poles are. I would argue, I'm going to draw a little bit because I think this article forgot to do one thing, right? They forgot to section the normal thyroid up here, which I would still do perpendicularly, perpendicular to the long axis. But then you would do the top of this nodule, change your direction, right? And then do the bottom of the nodule. And this allows you to see all edges in a perpendicular fashion. Does this make sense? I don't think I have this in the grossing online manual, but I can certainly add it in there. Arguably, this is a more thorough way to evaluate those nodule poles. The people that did this study said that they only identified like one case with one extra focus of capsular invasion at the poles. So it may not be super clinically impactful. So if you want to do it, that's great. If you don't, it probably doesn't have too much clinical impact, but I do think it arguably is a better way to evaluate. Okay. Questions, comments? All right. The last.
Sorry, just a quick question.
Mhm.
Can you go back to the last picture, the one previous to this? Yeah. So I guess if okay. So if you're no, go back.
Sorry.
If your tumor is getting to the lateral edge of the capsule, oh, it depends on which way. Never mind. Okay, I got it.
Okay.
Sorry.
No worries. Okay. All right. So other thing I just want to mention briefly is why have I now asked you to look for extrathyroidal extension? So this is due to updates in the 8th edition. Oh, I'm sorry, it's 9. If you have to leave, go ahead. This won't be long, but it will be recorded. All right. Updates to the 8th edition of the AJCC staging system require gross examination of extrathyroidal extension in order to update the state, to up the stage. So what does gross extrathyroidal extension look like? Look for large vessels, look for skeletal muscle. If the surgeon took a wide margin, that probably means he or she had a hard time getting the thyroid out and it was stuck to those structures, and it probably implies gross extrathyroidal extension. So why, again, do we evaluate for this? Because in the old AJCC staging system, any microscopic ETE into fibroadipose tissue, into muscle, whatever, resulted in an upstage to T3. Now, it is only gross or macroscopic extrathyroidal extension into skeletal muscle that upstages the patient. So tiny microscopic extension into fat, not upstaged. Gross macroscopic extension into skeletal muscle, yes, upstaged. So the gross impression is very important for the stage, all right? So we as pathologists can identify gross extrathyroidal extension on our cut sections, and we can identify microscopic extrathyroidal extension on our H&E sections. In this case, I'm showing you infiltration of the PTC into skeletal muscle. Right, when I see infiltration of PTC into skeletal muscle microscopically, I ask you, did you see it grossly? And I ask the surgeon, did you see it intraoperatively? Because if they said, oh yeah, it was really stuck to muscle, I had a hard time getting it off, to me that's gross ETE, to me that upstages the patient, right? So this is a clinical pathologic correlation now that we have to do for ETE. All right, The last thing I'm going to talk about is just calcification and decalcification. Does anybody have questions? 100% attendance. Woo. All right. Calcification and decalcification. This is important not only for thyroid, so keep this in mind for any specimen that is hard, calcified, bony. All right. In the thyroid, what are you going to encounter? You may encounter peripheral eggshell calcifications that are coarse, that you see in follicular neoplasms, and you may see internal fine microcalcifications like in PTC. All right, those are the different calcs for thyroid, coarse and fine or micro. Micro implies PTC, sometimes medullary. All right, we are doing molecular testing for thyroid not only on FNA, but also formalin-fixed paraffin-embedded blocks, which is usually our in-house NGS for DNA mutations or RNA fusions. So in this case, we need tumor that is either undecalcified or decalcified in gentle EDTA. Those of you who've heard me talk about this before, again, I am a broken record, but we've had issues in the past, therefore I like to restate it every time we are dealing with a potentially calcified lesion. So in our pilot study years ago, we looked at 5% EDTA, which is gentle, and we looked at no decal, and both met molecular criteria for adequate DNA. We looked at our standard decal, which is hydrochloric acid, and we looked at this other formic acid, both very bad, all right? So HCl and formic acid, bad for molecular testing. So we know 5% EDTA worked. We went back and we looked at 10% and 18% EDTA. Amazingly, both of those also worked. So tissue submerged in 10% or 18% EDTA for up to 3 straight weeks, not removed, 3 straight weeks, were fine for molecular testing, all right? So what I will tell you is if you ever need EDTA decalcification, we have 10% in the gross room. Ask me, ask a PA. You can keep it in here for up to 3 weeks and it will be totally fine for molecular. Hopefully you won't need 3 weeks. It is slower than the regular HCl, so you may need a few extra days, but arguably isolate soft tumor that doesn't need decal if you can, or decal a couple sections in EDTA. I would argue if it's a large tumor, maybe a few, to make sure we have adequate tissue. But it works, it's great. Thank you. You may ask, why are we testing FFPE tissue? If it's not already done on FNA, we may do it for diagnosis of follicular neoplasm versus papillary carcinoma genetics, if there's ever an equivocal case, like a NIFT-P, for example. We may do it for prognosis. Are there aggressive mutations like TP53 or TERT? Also clinically for treatment. So BRAF V600E has an inhibitor. NTRK fusion has an inhibitor, right? So clinicians are asking for molecular testing on everything. So do not assume that you can get away without it in these days. Just assume that you need it. Even if they didn't ask for it on their requisition, just assume that they're going to need it because eventually they will ask for it. This is the world that we live in. Okay. So in summary, when you're grossing those thyroids, always check your imaging and your FNA results prior to grossing. These items will inform your gross evaluation and may alter your sectioning. Correlate the imaging with the gross findings. Beware of those calcified tissues or tumors involving bone. Please ask me if you have any questions or need help. Call my cell, text me, call my office. Most of you know how to get a hold of me, but I'm always available. Even if we do FaceTime, we've done that before. Send me pictures on my phone if I'm not here. It always works. We can always communicate. So thank you guys for listening. Let me know if you have questions.